Dear friends, it's a very exciting symposium of three very important advances and which has a lot of clinical, practical utility in diabetes mellitus. And we have excellent speakers, as you will see as the time pass by. It's my pleasant duty to invite first Dr. Mark Walker to speak to us on a very important topic, looking for MODY, looking for LADA and other forms of diabetes, in whom, with what and how. A very practical and clinical topic. Dr. Mark Walker is the Professor and Honorary Consultant Physician at the Newcastle upon Tyne Hospital in the UK. He is the Associate Dean for Clinical Research and Director for the Newcastle NIH Clinical Research Facility. He has been the past chair for the EASD Scientific Program Committee between 2010 and 2013, a very important assignment. And his research interests are on the genetic basis of type 2 diabetes, the mechanism of insulin resistance, and the mitochondrial diabetes. And I must tell you that he has worked with the great names from Giorgio Alberti to many other names in the field of diabetes. And here, dear friends, I present to you Dr. Mark Walker for this very interesting topic.
Thank you, Dr. Das. Can you hear me? Yep, okay. So, first of all, I'd like to thank the faculty for inviting me. It's a real pleasure. It's my first time to India, so I'm learning a lot and having a lot of fun, and it's good to catch up with old friends. Dr. Muthu, who invited me, he worked with us in Newcastle and did his PhD there, and so it's nice to catch up and see how well he's doing here. So what you'll see first of all that I've changed the title. I hope you don't mind. It's the same topic, but what I don't want to do is to burden you with facts. That's not the purpose of this this talk. It's essentially to guide you through how you might manage and assess a patient who you think might have monogenic diabetes. So it's an approach. It's an approach we've developed in Newcastle. We collaborate with Exeter, who's our local, our national MODY group. And this is a kind of a work in progress, but hopefully it'll give you some guidance. So let's move on. So the first point I want to make, this is these are the European data, but you'll appreciate, I think it applies here as well, that the risk of diabetes, this is the incidence, and this is age along the x-axis, and these are the age categories. And you can see in blue, this is the incidence of all diabetes, in red is type 1, and then in green is type 2. And you can see type 1 tends to peak in the middle age and then starts to fall down, whereas type 2 goes up progressively. But here in the younger adults, I'm thinking of people in their 20s, 30s, the incidence of both type 1 and type 2 is high, I mean comparable. So already there's, in terms of the incidence, we can't really be guided as to what it might be in terms of what the patient may have. If you look at the WHO classification, they talk about type 1 and type 2, and then they talk about other specific subtypes. And this is way out of date, okay? But it's useful to just look at how they define genetic defects. And they're talking about monogenic of the beta cell, and they talk about MODY and mitochondrial diabetes. And I'll talk about each of those in turn. Now, what I like to do when I talk about clinical situations is to give examples. And so I'm going to present you some of my patients and just tell you how we approach them, the clinical characteristics. So this is a lady who is, she's called Sharon. She's age 45, but back in 1983, and I'll tell you how long ago, that's kind of ancient history because I graduated in 1983. So it kind of has some real meaning, significance for me, but it had significance for this lady because she was diagnosed with diabetes at the age of 16. Now, the physicians who were looking after her were on the ball. because a lot of people would just say she's 16, she's young, it's type 1 diabetes, stick her on insulin. But they were on the ball and they realized that she didn't have ketones, she didn't have weight loss. So they say, well, maybe it's not type 1, it could be non-insulin dependent. So they actually gave her a sulfonylurea. But she stopped it fairly quickly because as she tells us now, and she remembers it vividly, this drug, the sulfonylurea, kept causing her to feel very unwell. She was having hypoglycemia. And because of this, she was having to eat a lot. And as a teenage girl, she was putting on more and more weight to avoid hypoglycemia through eating. And so she stopped it. And then, so the doctors said, well, okay, the sulfonylurea's worked, so let's put her on insulin. And that's okay, insulin works, it's a good treatment. And so that's how she was managed. In 1984, a year later, her mother was diagnosed with type 2 diabetes. Now, coming back to Dr. Das, he mentioned my mentor, George Alberti. Well, this lady, her mother, presented to George Alberti. She still asks after him. But George diagnosed her with type 2 diabetes. And that's because she was quite elderly, she was in her 40s, and she had the classical presentation. But I'll come back to Mum a little bit later. 1986 to 2002, quite a long period, but with Sharon, this is the proband, she had very poor blood glucose control. She kept coming to the clinic and she had terrible hemoglobin A1C values. They averaged around 14%. And after many years, she admitted that she wasn't taking her treatment because she didn't like the insulin as well, because she was worried about her weight. So basically, she wasn't getting any treatment, but certainly she didn't develop ketoacidosis. So she was secreting some of her own insulin, but it was negligible. In 2002, we got a bit more modern, and someone said, well, let's check a C-peptide and GAD antibody status. And she was C-peptide positive. Well, we knew that because she was surviving without insulin. GAD antibodies were negative, so we could put in the notes that she was not type 1. But at that stage, more importantly, from a clinical perspective, she developed diabetic retinopathy. Okay, quite a problem. Then 2006, so not so long ago, one of our bright young registrars said, could it be MODY? And she said, well, no, because my mum's got type 2 diabetes. That's clear, and the professor diagnoses, so it's got to be right. But actually, and this isn't a slight on George Alberti, by the way, because he was probably traveling a lot. He probably didn't see the patient. But they did a genetic screen, and she turned out, this is the proband, Sharon, had HNF1 alpha mutation. She had a form of MODY. And when we looked at the whole family, so this is Sharon here, she's mutation positive. Mum, with type 2 diabetes, presented in the 40s, had MODY, she's got the mutation. Her maternal uncle has MODY, and Sharon's 2 children, although they don't have diabetes, one is healthy and does not have the mutation, whereas the other son does, but doesn't have diabetes yet. And just to complete the story of this Sharon, the story so far, that is, 2009, her eye disease has progressed to proliferative retinopathy. She's required bilateral laser treatment. She has a raised blood pressure and cholesterol. And in 2012, she developed kidney failure. Actually, she'd been progressing over a number of years, but she reached end-stage renal failure and is currently being worked. She's on dialysis now, and is being worked up for pancreas and kidney transplantation. So this is a young lady, well, she's not young anymore, she's 45, but she developed MODY, but has quite severe complications. And just if you look at the formal definition of MODY, it talks about early onset non-insulin dependent diabetes before the age of 25. That applied to Sharon, but it certainly didn't apply to her mum. Autosomal dominant pattern of inheritance. It's rare, and it used to be assumed to be a single condition, but we know it's much more complex now. And this is, again, I'm not going to go into vast detail, but if you look down here, these are the different MODY subtypes. So MODY 3, this is the HNF1 alpha mutation that Sharon has. This is in the European families, this is the most common cause of MODY. But what's interesting, the penetrance, in other words, if you carry the mutation, at what stage do you develop the phenotype, in other words, diabetes? It's highly penetrant, so by the age of 40, 90% of mutation carriers will have diabetes. And actually, I suspect Sharon's mum, although she presented age 42, I think she probably had undiagnosed diabetes before them. So by the age of 40, most patients, if you carry the mutation, will have diabetes. The other, HNF1 alpha is a transcription factor. It affects beta cell function. There are other transcription factors, HNF4 alpha, 1 beta. The phenotypes are very similar to 1 alpha, except that 1 beta, they also get renal problems. Glucokinase is different. It's not a transcription factor. It's an enzyme. It encodes an enzyme that is basically the glucose sensor of the beta cell and regulates how much insulin you secrete. So let me tell you about another patient. This is a guy called Paul. When he presented in 2006, was age 35. And at that time, I was still doing general medicine. And Paul presented on my take, a general medical take, with a left low lobe pneumonia, and that was his main problem. But again, because we checked various things, we realized that his random blood glucose was a little bit high, not particularly, it was 10, but the keen junior doctor working with us decided to do a hemoglobin A1C, and that was a bit high. In fact, it was a bit higher than we would expect. And so we thought, well, could he have diabetes? So once the pneumonia had settled, we did a formal test, and sure enough, his fasting blood glucose was 7.2. But again, he was GAD antibody negative, and we told him he had diabetes, and he was a bit of a lad. And he said, well, so what? You know, I'm not going to do anything. He was skinny as well. But he did say that he had a positive family history. And this is the family. So here's Paul. We didn't know anything about his parents. Both had died relatively young. But he could tell us that both his sisters had diabetes. One was on tablets, and this one the eldest one, had gestational diabetes every time she was pregnant and every time she'd required insulin. And we did a mutation screening, and this family turned out to have a glucokinase mutation. So we're diagnosed with MODY too. Now, for Paul, who's a bit of a lad and doesn't really engage with the diabetes service, this was the best form of diabetes that he could have wished for, because it doesn't really need much intervention. I saw him for a number of years afterwards on an annual basis. His hemoglobin A1C was rock steady, his weight was steady, and basically he's not required any treatment. And so that's the beauty of glucokinase mutations. It tends to be a relatively benign condition. The risks of complications are low. And so in terms of comparing HNF1 alpha, I've given you an example with Sharon, and glucokinase Paul. Hyperglycemia tends to be marked in the HNF1 alpha. The disease tends to progress with HNF1 alpha. So while they may start off on sulfonylureas, they can and often do require insulin therapy, whereas glucokinase tend not to require any treatment. Complications as a consequence of the progression tends to be higher in HNF1 alpha. Sharon's got diabetic eye disease, kidney disease. And as I say, sulfonylurea sensitivity is particularly a feature of HNF1 alpha. So that's okay. Let's just take you to, and this is just to illustrate the point that HNF1 alpha actually behaves like type 2 diabetes. It tends to be progressive. You get progressive beta cell failure, glucokinase not. And what about yourselves? What about India? Well, I did a search of MODY in South Indian Asians, and I was interested to see that a study's been done here by Dr. Mohan and in collaboration with a Danish group, and they took people who had clinical features of MODY and then said, well, if we screen them, do any of them carry MODY mutations? In this case, they focused specifically on HNF1 alpha. And they found a number of mutations in these number of subjects. I think there are about 50 patients altogether. They extended it in terms of the family affected. But what they found, the overall prevalence of this group that they screened, their probands, 9% carried HNF1 alpha mutations. So it exists in South Indian Asians. But what was interesting, they made the point that unlike the Europeans, it does not seem to be the most common form of MODY. Now, there's a slight caveat to that, because it does beg the question whether the group that they picked up clinically really fitted the true phenotype of MODY. It's very difficult, particularly in terms of the family history, young type 2. A lot of them have a pattern of inheritance that looks very similar to MODY. But the point here is that HNF1 alpha mutations occur in your clinical practice, assuming that they're representative of the Chennai cohort. And what about MODY in the UK in Asian families? We collaborate with the Exeter group, and they screened patients with diabetes aged under the age of 16 with just one parent with diabetes, so not two, just one, again looking for the autosomal dominant inheritance pattern. And they identified 3 Asian families with mutations. 2 had an HNF1 alpha mutation, and 1 had a glucokinase mutation. What was interesting is that when they looked at the phenotypes of these Asian families with the mutations, the phenotypes were the same as described in the European families. In other words, sulfonylurea sensitivity was a feature of the HNF1 alpha mutations, and the glucokinase family had a benign form. So this is very important and useful. The mutations, whatever the ethnic background, seem to keep true to their phenotype. So one of the difficult situations we are coming across more and more, and I think it would certainly apply here, is distinguishing between HNF1 alpha MODY with the complications and the clinical features very similar to young type 2. Because as I say, both HNF1 alpha and young type 2 tend to have a family history of diabetes. The young type 2 tend to have both parents affected. But it can happen that they just have one and it's not showing up in the other parent. So family history is common in both forms. Diabetes progression is common in both forms. Complications with time are common in both forms. So, okay, you've got a patient in front of you in your clinic, they're young with non-insulin dependent diabetes. Is it MODY or is it young type 2? So there are a few things that might point you in one direction or the other. Certainly you can just go ahead and screen for the mutation. Okay, you could do a screen of HNF1 alpha, do a full sequence screen. It's expensive, but you can do it, and that will give you the answer. So that's the gold standard test. But if you want to try to dissect them out a little bit before you do the genetic screening, well, as I said, sulfonylurea sensitivity is a good marker, and certainly we sometimes, if we're not sure, we'll do a kind of a clinical trial within the patient, starting with a very low dose of sulfonylurea, giving them a blood glucose monitor and see how they respond. And again, if there's any evidence of sensitivity, we would then proceed to screening. Back home, BMI is a useful marker of which way it might be. So certainly our young type 2s tend all to be obese. BMI greater than 30, the HNF1 alphas tend to be below this. But again, it's not a hard and fast rule. And I understand in India that a lot of your type 2s do not have marked obesity, that it tends to be more central obesity. So BMI may not be so useful. High sensitive CRP is emerging as a useful marker between the two. And it's been found that like general type 2 diabetes, young type 2 tends to have a raised high sensitivity CRP, whereas HNF1 alpha, this is work that's come out of Oxford, tends to be low. So that's another useful guide, and we're tending to use that in clinical practice. Got a bit more time, I think. Can I press? So I'm okay, am I? Okay, so I'm taking a bit longer than I should, but anyway, mitochondrial diabetes. This is close to my heart because I do a lot of research in mitochondrial diabetes. This is an EM slide of a mitochondrion with the Christie. And the point about mitochondria, they have their own DNA, and you're probably all aware of this, but mitochondrial DNA is its circular structure, and it encodes some of the proteins that form part of the respiratory chain in the mitochondria. But the key features that are, again, important for the clinical elements is that the human mitochondria, there are many copies within the cell, within the mitochondria, but all of our mitochondrial DNA comes through our mother. So it's maternally inherited. So my mitochondrial DNA came from my mother, yours, everyone's. And because of that, if you carry mutation of mitochondrial DNA, it's carried through the maternal line. It's a maternal inheritance pattern. And so here's a family, this is the first family that we picked up with mitochondrial diabetes. We were doing a study, a family study, and just a general family study of diabetes, and David came along and we diagnosed diabetes. And his sister came storming along the corridor and said, "What are you doing? We've got lots of pathology in our family. Why are you diagnosing diabetes, more diabetes in our family?" So I sat Sylvia down and I said, "Look, just tell us about your family." He said, "Well, first of all, we're all deaf. Secondly, there's a lot of diabetes. She had it. Gillian, who sadly died, had it. Now David's got it. And her mother had diabetes, deafness, and what she called dementia, but in retrospect it was a neurodegenerative part of the disease. And basically we found that they had a mutation in this part of the mitochondrial DNA, which is the 3243 mutation. This, certainly in European population, this is the commonest cause of mitochondrial diabetes. And the phenotype is maternally inherited diabetes and deafness. And I say this is the classical presentation. They present with sensory neural deafness, usually before the presentation of diabetes, so it's usually in their teenage years. Diabetes presenting a little bit later, usually middle age. There's often, but not always, a progression to insulin therapy. They're antibody negative, and again, it's quite rare. We calculate it's about 1% of our population. Does it occur in South Indian Asians? Yes. There was a study between a group in Sri Lanka and my colleague Mark McCarthy in Oxford, and found this mutation in the population, again at around the same prevalence of around 1%. So to finish, this is my last slide, Mr. Chairman. This is our approach, and it's pragmatic, but it's a kind of a guide to how we approach young people presenting with diabetes. Our first question is are they ketone positive with or without weight loss? And certainly if there's features of type 1, it's quite easy. They go off and we manage them as type 1. C-peptide, it was asked in the last talk, C-peptide can be positive in newly diagnosed type 1, but if it's negative, it certainly helps and it points this way. GAD also, if they're positive, points this way. So we're going along this line. If the ketone, if they don't have ketones, if they're C-peptide positive, then we're going along this route. And this is the tricky bit, as I've said, in terms of clinical management. Is it young type 2 or is it monogenic? And we use these markers, so if it's less than 30 BMI, if the CRP is low, and particularly if there are other features such as sulfonylurea sensitivity, gestational diabetes or deafness, all of these things point us to this route and we would do genetic testing. If not, then we go to type 2. Now, what I've got to say, this is not cast in stone. One of the most important things I tell our juniors is that the priority in managing these patients is to make them safe, even if it means putting them on insulin first of all, because you can always go back and review the diagnosis later on, and the diseases progress, and you can then make a diagnosis or re-evaluate the diagnosis later. But so even if you start putting them on insulin, everyone up here on insulin, it doesn't matter, they're safe, and then you can buy time and then look at the diagnosis. So that's my last slide, and I'm happy to take questions. Thank you.
I think we'll have the questions together, all the three topics. Okay. And thank you, Mark. I mean, beautifully, you have given an overview of the MODY and also the MIDD, and through three illustrative cases, you have taken us through the most significant HFN-alpha and also the glucokinase deficiency, glucokinase gene associated MODY, and also